have another problem.
Yes, I think so. She has started screen sharing, but it's not appearing here.
All right, it's there.
Let's start with the first question, sir. The question 4. 3.5-year-old boy is admitted with a 4-day history of fever and cough. He had taken medication from the central dispensary, and only paracetamol, chlorpheniramine, and salbutamol in appropriate doses were given. He has not opened his bowel for 2 days but passed urine for 3 times during last 24 hours. He is the second child of the family of 3 with a 5-year-old sister and 4-month-old brother. The first hospital admission, and the father had not brought any previous records. On physical examination, his growth parameters are as follows. Weight is 10.3 kilogram, minus 3 SD on weight for age child. Then height is 92 centimeter, minus 2 SD in height for age child. Weight for height is below minus 3 SD. He is febrile, ill-looking with some dehydration. Examination on the cardiovascular system reveals a pulse rate of 140 per minute, and the blood pressure is 80 by 45. His respiratory rate is 48 breaths per minute with intercostal subcostal recession. There are coarse crepitations in both lung fields. The abdominal examination reveals hepatomegaly and splenomegaly. Both are 1 centimeter below right and left costal margins, respectively. His central nervous system examination is unremarkable, and investigations are as follows. Full blood count, WBC is 23, with neutrophil 82%. Hemoglobin level is 8.6, and MCV 62, MCH is 24, MCHC 29. Red cell distribution width is 18.5, platelets 489, CRP is 195. So this is the key medical problems in child. So according to the given history, child has
Yeah,
severe.
now when you are reading this, in the first chapter, first paragraph, what do you get?
It's about the history of the child's presentation and the.
No, what is the history?
Yes.
At the end of the first
4-day.
paragraph itself, you should have certain points either underlined or marked.
Yeah.
So what
4-day
are the main things?
fever. 4-day history of fever and cough.
Yeah.
Not
So when you get that, where do you think the problem is?
in the respiratory systems.
Yeah, looks like a respiratory tract problem. Right.
Then he has taken the medication.
Yeah. And what is specific about the medication?
There's no antibiotic.
Good. Right. Then.
And he has not opened the bowel for 2 days, but passed urine 3 times during 24 hours.
So what does that mean?
Due to poor feeding.
Yeah. And
So the respiratory system infection is
poor
persisting.
feeding is there. So there is some amount of relative dehydration is also there. That's why once in 8 hours, on average, he has passed urine. No?
Yes.
Right. Then, so it's a relatively somewhat ill child with a 4-day history of going on respiratory tract infection with poor intake of oral food and fluids.
Good. Yes.
Right. So is there constipation there?
It says bowel has not opened for 2 days. There can be.
What is constipation?
Um,
What is constipation? What is the definition of constipation? Hmm? It's passage of hard,
hard stools for
infrequent, or hard stools. So there is nothing. Just 2 days of this thing does not mean that there is constipation. It has not been a long-standing thing.
yes.
So many have in at this exam also have written constipation, which is totally wrong. Guys, we have not said consistency or anything. We have said only for 2 days the bowel had not to open. Then on the other hand, you have to take there is acute renal injury also because there is only 3 urine outputs for 24 hours. You don't say like that. So that has to be, I mean, you have to be careful about that, right? Okay, then second paragraph.
He's the second child of family of three with 5-year-old sister and 4-month-old brother.
Hmm.
Uh,
What do you call that?
3.5 years means there's no adequate spacing between the
Yeah, more than that in community medicine.
uh,
What do you call that family? You take them as a high risk family because there are some 3 children below 5 years of age,
uh,
right?
okay.
So much, right? Okay, then at least if there was 2 years of gap, then the eldest should be 6 years, no? Right. Then
Yeah.
third para.
On physical examination, growth parameters as follows, saying weight is below -3 st, uh, and height is 92 below -2 st, and weight for height is below -3 st, suggestive of severe acute malnutrition.
Yeah. So basically, SAM. So in front of that severe acute malnutrition with mild degree of stunting is also setting in, right? Then
Uh, he's febrile, ill looking with some dehydration. Examination of the cardiovascular system reveals pulse rate 140 and blood pressure is 80/45.
hmm.
Respiratory rate is 48 with increased work of breathing with intercostal and subcostal recessions. So the post crepitations in both lungs are also there, and abdominal examination reveals hepatomegaly and splenomegaly,
uh,
1 centimeter below. Uh, Nervous system examination is unremarkable. So in the given picture, the is tachypnic, tachycardic. Uh,
so how would you interpret those?
so kind and is febrile ill looking. So kind of a septicemic picture.
Why do you say septicemia?
Uh, the febrile ill looking tachycardia and
So those are septicemic. Even if they have a respiratory tract infection, they will be febrile, ill. And now with the respiratory rate of 48 and intercostal subcostal relation, what do you call that?
uh, increased work of breathing.
Yes, but overall, what do you call that? Hmm? What do you
Uh,
call it?
Distress.
The respiratory distress, right? Then
Yes.
140 heart pulse rate and 82/45 blood pressure.
80/45. So it's
So there is relative
what?
dehydration.
Yeah.
So there is compensated. Fever is also causing the tachycardia, but the pressure is also slightly low, right? So there is some amount of that. And also the systolic as well as diastolic low. So then you can say, okay, there can be some amount of mild amount of septicemia may be setting in, right?
Okay. So
So the post crepitation in both lung fields means what does that mean?
suggestive of a pneumonia.
Yeah, so there is lower respiratory tract infection, right then.
And the abdominal examination reveals a hepatomegaly and splenomegaly. Can be due to chronic malnutrition.
Partly it can be due to that, as well as it can be also due to certain degree of septicemic setting in, severe infection. Right, okay. Going on to this thing.
Uh, in the full
Investigation. So
yes,
it is in summary, how would you describe this child?
is having lower respiratory tract infection. Child with the severe acute malnutrition now presenting with the severe lower respiratory tract infection.
Yeah, with a little relatively poor or at risk home front, right? With some
Of
amount of dehydration, ill, a child, a severe acute malnourished nutrition child with presenting with may mm, severe acute malnutrition child presenting with lower respiratory tract infection associated with respiratory complicated by respiratory distress. And so that's the main thing, and some amount of dehydration. Right then,
course. In a full blood count wise, there's a WBC level is elevated with
good.
new
Move it
leukocyte.
up, move it up, cancer. Hmm?
Uh,
Move the screen up. Move
Hanseni
it.
can Hanseni.
Can you scroll it up? Answer is the I'll have logged in and gone. Huh? Huh? Helpful.
Ashi.
Huh?
Uh, Full blood count is WBC level is elevated with neutrophilic leukocytosis, and HP level is low. Being the MCV and MCHC both are low, suggestive of microcytic hyperchromic anemia.
Hmm.
And red cell distribution with this increased, so the suggestive of iron deficiency.
RDW is very high.
High. The platelet level is 489. It's slightly increased, and
Right.
CRP 195, suggestive of a acute inflammatory response in ongoing inflammation in the body.
Right. Okay. And then,
So the anemia part could be due to this associated malnutrition.
hmm,
The full blood count elevation with neutrophilic leukocytes could be due to the bacterial pneumonia.
so there is a bacterial infection where two inflammatory things, WBC is high, CRP is high, and they are very high. So that means suggestive of bacterial infection. Then hemoglobin is low with a microcytic hypochromic picture with a increased RDW, because anemia with microcytic hypochromic could be even thalassemia on counts. But when the RDW is more than 14.5, it is suggestive of iron deficiency. Then platelets will go up because there will be anemia. In the presence of anemia, the bone marrow will be non-specifically stimulated. So in that case, the platelet usually will be around higher above the normal level. It is not otherwise any other illness. Okay,
Okay. Sir.
right. So then,
Uh,
So what are the key medical problems?
So as we identified from the first paragraph, there was a respiratory tract infection, and then it's suggestive of a lower respiratory tract infection. So the in the according to the physical examination, child has severe acute malnutrition, uh, and then
So overall, you have to tell them now respiratory, there is a low respiratory tract infection. Can you qualify it a little bit more?
uh, severe respiratory
Yeah, severe
lower
respiratory tract infection, not respiratory tract infection with respiratory distress.
distress.
Okay.
And then this severe acute malnutrition part, then
Okay.
the chronic nutritionally, the iron deficiency anemia is there,
Yeah, iron deficiency anemia.
and then there's some dehydration also.
Okay, yeah.
Then community wise, there's a high risk.
Yeah, it's a medical problem, sir.
Okay.
That is not a medical problem. You have to read the words carefully. The key medical problem. So it is with complicated respiratory, lower respiratory tract infection. Then there is iron deficiency anemia, severe acute malnutrition. There is even you can say some degree of early stunting is there. And then there is some dehydration is present. Okay.
Okay, so when
Right.
we are writing to that answer, so do we need to categorize it like respiratory problems and say this
No,
severe
no.
pneumonia, or
It's
just
only one thing, one line.
okay,
You don't have to say respiratory tract infection, severe, 1, 2, 3, and so under 4.1, you have 4 points. Number one, severe respiratory distress. Sorry, lower respiratory tract infection complicated by severe respiratory distress. Number two, or you can say even a bacterial thing because it's all point towards a bacteria. Then severe acute malnutrition. Then early stunting. Then iron deficiency anemia. And then some dehydration.
okay.
Right. Okay, then.
Uh, Outline the management of the child during next 24 hours.
Mm.
Uh, According to the presentation, uh, I will approach the child with the ABC approach with the aim of stabilizing the child. First, go through the airway breathing and circulation, and ensure the patency of the airway and breathing wise. So the auscultation findings are already given, which is the sorry, yes, the cross crepitations in both lungs field. Then I will measure the SpO2 level, and if it's below 92, I would start the uh, uh, high flow oxygen. Then circulation wise, the secure two IV lines and started fluid resuscitation if necessary. Uh, so
Resuscitation care මොකක්ද?
uh, Still the BP is picking up
I mean,
by
yeah,
40.
why do you think? You think the child is in septicemic shock? Have they said that there is cold peripheries, undetectable blood pressure? There is
Uh,
nothing, no?
no, no, sir, nothing.
So don't doubt about those things. Now, if you have this child seated in front of you, what would you do?
Okay. Then after that, I will start the empirical antibiotics since
Huh?
uh, so preferably IV.
නෑ පුතා දැන් මේක පටන් ගන්නකොට ලෙඩ ආව ගමන් කෙලින්ම IV ගහනවද? Okay, right, right. Because the investigations have been given, now you can start from there, right? Okay. Anything else you want to do? You are being given certain amount of investigations. Is there anything else you want to know?
Uh, whether the culture have been taken.
You can say what? Huh?
Uh, the sputum cultures
Why sputum culture?
coming with respiratory tract infection.
There is no rest. You more than sputum culture. If this child is ill, you have to take a blood culture. No, no, you have a mildly palpable liver and a spleen. So you don't know whether we are going into septicemic, sorry, in back septicemia. So then you have to see that. So the main thing is that you have to do a blood culture, right? So you get a blood culture. What else you want to do? Hmm? Other than a blood culture, what else you want to do?
A chest X-ray.
Just it should be done now. Like then,
Then we can start monitoring the child, the urine output and the input charts. So, and then I would like to take a temperature chart also. So then if there is some dehydration, they advise the mother to give oral fluids uh, as needed.
mhm.
And
So you take any missing investigations. So what is needed at the moment is blood culture and chest X-ray, right? Then you will take, then you have to do the start the monitoring, and then you start the antibiotics and other medications. Now they are not brought it, no. So paracetamol for the temporary. So monitoring is what are the thing monitoring?
can monitor the heart rate, the respiratory rate, and the SpO2 and blood pressure.
Yeah. So how what is the frequency? All that you are right. Hmm?
Initially, uh, we can go for hourly monitoring, and if
What
the
this you have to say. Are you have to say that. Then
then the supportive therapy with the temperature control for paracetamol for as an antibiotic, and then uh,
okay. Then
assess the level of dehydration. Uh,
okay. Now you have assessed. Now you have got an idea. No.
yes.
Then you have the monitoring you'll do. Then you have the antibiotics and antipyretics are given. Then what else?
So we can address the nutritional issue. Then
What about the fluids? You have to
uh,
give the fluids.
yes.
Right? And then else? Hmm? Ramanan?
Anemia management.
Yeah, you have to do the anemia management, but you can usually wait a little because usually we don't give iron during a acute febrile illness. Right? Then, and what else?
Then about the feeding for this
Yeah.
child. So
Okay.
since severe acute malnutrition, we can start around reduced therapeutic food.
Mm.
Uh,
But usually, what do you start with these children? Hmm?
BP 100.
Yeah, you start before BP 100. Now, this child is ill, no? So, if he's ill, what do you feed him? What is the starting this thing?
So we have to use a small frequent feeds.
More frequent feeds, correct?
F75. So
Uh,
okay.
yeah, you have to start with small, maybe hacking. F100, F75, then you move on to F100. So, like that, you have to then increase that. Okay,
Okay.
right then.
Uh, then I think so the first 24 hours,
Yes.
that
So,
is.
2 hours, you will start with oral fluids.
Yes.
No, sorry, with F75, low diluted eh, milk. Yeah, basically milk. And then with that, you will gradually, eh, later on, you can gradually increase the, uh, what do you call, increase the concentration. I mean, first day or first 24 hours. So you can start it and you can say if the child is ill, I will put a NG tube and may give him orally. Via NG tube. Alright?
Okay.
That way you can get it. Right then,
Um,
yeah, what? So those are things. So mainly it is investigation, then the monitoring, then the medication, and then supportive treatment. There is no documentation or notification here, no. That is also you have to remember if it was a dengue patient like, then also you have to send for notification. Right? Okay, then.
then the next question: the child recovers uneventfully after 5 days of treatment. Outline the long-term management of the child and family. So
Right.
for the long-term management, so the nutritional rehabilitation that we start in the ward initially should continue.
Right.
So we can do it through the clinic, and so stepwise we have to treat it and should be avoiding the refeeding syndrome initially, and then from the clinic we can go for the BP 100. Then when he comes for the moderate acute malnutrition level, we can start the three portion, and then the step-by therapy can be initiated from there, and the micronutrient deficiencies should be addressed. So since there was an the iron deficiency anemia, the iron supplementation uh, uh, should be arranged. So then for the anemia, follow-up should be done uh, by repeating this full blood count after 4 weeks time, uh, and assess uh, uh, the response to the therapy. Uh, and since there are so many previous records available, I would like to check the immunization status of the child. And if there's any missed immunizations, I would like to arrange that also. Then, so if there has been so previous illnesses, if there's
Huh?
had previous illnesses, so I would like to work up for the underlying cause for this, uh,
Uh-huh.
taking to assess if there's any signs of negligence or screening for TB and other infections. And most importantly, the family education I would give to the parents to recognize these danger signs such as tachypnic, the fast breathing, or the poor feeding and lethargy, so that they need to bring the child to the hospital early. Otherwise, can go into dehydration. And so I will improve their early health seeking behavior, and about the hygienic practices and infection prevention in the home, since there are two other children also there. So and uh,
Yeah. So those are the main things. And contraception to the mother, the family.
yes,
Don't forget that, because if the fourth child comes in, what will happen?
another economic burden and
Yeah. So you have to remember that also.
others.
Okay. Right. Mhm. Yeah. So those are the main things that you have to take care of it. And but what about so the main points are, if you summarize for that one.
Uh, I'm sorry for that last question. The,
Yeah.
uh, so then the nutritional aspect, the nutrition rehabilitation, and getting the child from SAM to MAM, and then
But
improve.
only nutrition rehabilitation,
Uh,
and ensure that the nutrition does not fall. Give advice right then.
and the correct any micronutrient deficiencies,
Right.
and the work up for anemia and immunization and evaluation of underlying causes. Uh,
Mhm.
and then the address the social aspect and the family education by the educating the family about the disease, infection control, and the hygiene, and most importantly, the contraception of the mother to reduce this economic burden. Uh,
Do you think you address all the problems there? Anything else left? Child and family. You say family, what is it? Hmm?
um,
You say child and family. What about the other two children?
yes.
You have to talk about the other two children. You have to assess the other two children for undernutrition, their vaccination, any other illness that they have. All that also have to be spoken of, right? You can't forget that. So this is where things go wrong for you. You miss certain paths. Okay.
Okay, sir.
Follow. Mm. Right, okay. Then,
Uh,
yeah,
yes,
next question. Yeah.
sir. Uh, question number 5. A previously healthy 4-year-old child presents with a 7-day history of fever and a 3-day history of generalized rash.
Your connection is not good.
She also complains of a sore throat
Uh,
and has reduced oral intake. On examination, she has some dehydration, an inflamed throat, and large cervical lymph nodes. Abdominal examination reveals a hepatomegaly of 2 and a splenomegaly of
Great.
uh,
Can't hear you. Mm. Connection falling. Mm.
and
And others, can you all hear? My connection problem or
Sometimes it's breaking up, sir.
lot of breaking up?
a previously healthy 4-year-old child present with a 7-day history of fever
Uh,
and a 3-day history of generalized rash.
uh,
She was complains of a sore throat and has reduced oral intake.
right.
On examination, she has some dehydration, an inflamed throat, and large cervical lymph nodes. Abdominal examination reveals a hepatomegaly of 2 cm and a splenomegaly of 1 cm. Uh, the first question is list 4 possible differential diagnoses for this presentation. So in the question, in first paragraph, we can see this is a previously healthy 4-year-old child with a 7-day history of fever and a 3-day history of generalized rash, uh, and a sore throat and reduced oral intake. So this is probably a prolonged fever. We
Okay,
can we
right.
can take under the pyrexia of unknown origin.
Lyrics of unknown origin.
Because of the fever and the rash, the um, possible
Yeah, but lyrics of unknown origin, right? So whatever it is, there is a throat-related infection going on. No?
yes sir.
Yeah. So what I going to do now?
Uh, so in first question is it is list 4 possible differential diagnosis for this
And
presentation.
sorry. And here,
Question number one is list four possible different
yeah,
diagnosis for
what
its
are the four
presentation.
possibilities? Hmm? Okay, what could be the four possibilities?
Yes, Kawasaki disease,
Okay, before Kawasaki.
uh, scarlet fever,
Okay, scarlet fever, good.
and acute leukemia or a lymphoma
Leukemia.
because of the lymphadenopathy.
Yeah, before that, a common infection.
Uh,
Yeah, common infection.
rheumatic fever,
More than rheumatic fever.
uh,
Hmm? More than rheumatic fever.
uh,
What about infectious mononucleosis? Yeah.
yes, sir.
Hmm?
Yes, sir. It is the first differential diagnosis. I think I told that, sir.
Mohammed Ahun, sorry.
First
I
one is
didn't
the
know.
infectious
I
mononuclear.
heard as
Second one
Kawasaki
is
disease, second.
yeah. Sorry, sir. First one is infectious mononucleus.
Uh,
Second one is scarlet fever. Third one is Kawasaki, and the fourth one is acute malignancy, just like leukemia or lymphoma.
okay, good.
And the second question is uh,
Uh,
two additional clinical features for each of the above differential diagnosis mentioned in
Sorry. So what are
five
the
one. So in infectious mononucleus,
uh,
there is a generalized lymphadenopathy and palatal fatigue.
yeah, Belter petechiae will be there.
Uh,
Right.
generalized lymphadenopathy
Hurry.
and palatal fatigue.
Hurry. Okay, then. Right. Okay.
And in and Kawasaki disease, there is bilateral uh, in Kawasaki disease. There is bilateral conjunctivitis, which is
Bilateral control.
non-purulent,
Right. Okay, good.
and we can see mucocutaneous changes like
Hmm. Cutaneous change. And there can be oral redness will be there. Third periphery
and
activity will be there. Swelling of the peripheries will be there. Hurry. Eat a person. Then what else? Where we are not getting connected?
In scarlet fever,
Right.
there is a sandpaper-like rash,
Okay.
and
Rash කියලා තියෙනවනේ. Now they have given a rash and rash, no, generalized rash, no. So you can't again say about the rash, no.
in strawberry tongue and circummoral pallor.
Okay.
In acute malignancy like leukemia or lymphoma, there can be a pallor and bleeding, and a recurrent infection history or the signs of recurrent infection, just like candidiasis or something, and also the bone pain suggestive of uh, malignancy. Uh, that's the for
Okay.
the four presentations.
ඊළඟට
The question number 3 is mention 5 investigations you would request given expected findings. Uh, so the first one is full blood count with blood film.
Okay.
In here, in infectious mononucleus, we can see lymphocytosis uh, with uh, atypical lymphocytes, and in leukemia, we can see blast cells, and also the pancytopenia with a high WBC count.
Okay.
Uh, and also, there can be thrombocytosis in Kawasaki disease.
So basically mention finding, you would request giving expected finding. So what are the 5 investigations again?
Uh, full blood count with blood picture,
Right.
uh, CRP and ESR.
Yeah, you can take them as separate even.
Okay, sir.
And then
Uh, liver function tests.
why liver function test?
Because in infectious mononucleus, because there is a hepatomegaly and splenomegaly, so we can
Here you can get, but
see
more specific ones will,
transaminase.
but it will, there is nothing called transaminases. All the book says that it's not inflammation or the transaminases. It is
Okay, sir. Uh,
what is, what is important is now for you to differentiate these illnesses. Now, if you do a full blood count,
yeah, then we can.
IMN will show a viral type of a picture. Kawasaki will show again increased WBC with increased maybe not platelets so early, but increased WBC with a bacterial type of or with neutrophil leukocytosis. Whereas in
Yeah.
IMN, it will be leukopenia with relative lymphocytosis. Right? Then
Okay.
if it is scarlet fever, then you will have again a bacterial type of change with normal platelet and HB. And if it is malignancy, there will be large amounts of counts, especially lymphocytes, because in this age it is ALL is the common one. So you will have large number of ALL with deprived or with thrombocytopenia and anemia. Hari? So this
Okay,
type
sir.
of a thing, you can even put it into a table
Okay.
and see where now you can write, okay, for the column number 1, 2, 3, you can write as first column you can give the main investigation. Then second column you can give subtypes of like that now, main investigation, full blood count, hemoglobin. Then you will have IMN, scarlet fever, Kawasaki disease, and ALL. Then what happens to WBC? WBC increases and neutrophil increases. Now in infection mononucleosis, WBC goes down, relative lymphocytes high. Scarlet fever, WBC high, neutrophil high. Kawasaki, WBC high, neutrophil high. This thing, WBC high in ALL, lymphocytes very high. So like that. Then you can write platelets. What happens is IMN, it is normal. Kawasaki normal initially, scarlet fever normal. In ALL, it will be reduced. HB, all three normal relatively, and reduce in within. Then you do a blood picture. So you will have in the blood picture the three differences in those three of those four, right? So there will be atypical lymphocytes in IMN. There will be blast cells in this thing, and there will be left shift with left shift could be there with the neutral lymphocytes, sorry, neutrophils, increased neutrophils with showing a left shift sometimes because it comes early, no? Then HB will be normal in the 3 and reducing that. Platelets, this is what, sorry, blood picture. So there will be blast cells in that. In Kawasaki, so it mainly neutrophil. Then you do a CRP. CRP will be high, low, sorry, slightly high in IMN, very high in Kawasaki and this thing as well as ALN. ESR relatively normal in IMN. Other two, there will be, especially in scarlet fever, slightly increased. And then Kawasaki and ALL, it will be more than 100. Usually it's above 100, no? Like that. So then you can do LDH, lactate dehydrogenase, which will be very high in ALL, whereas in the other three it will be normal. Like that you can write. So you have a table, it would be much easy rather than spelling out because somebody can read the table easily, you know. Otherwise, you have to say every time full blood count, you have to list ALL, Kawasaki, all those things, right?
Okay, sir.
ඊට පස්සේ
In specific wise, we can do
correct?
specific antigen test, antibody test, and monospot monospot test.
Right. Okay. All right. Then, so what is the initial management of this patient? And
For Kawasaki disease, we can do cardiography for coronary artery dilatation. Um, First, we have to admit the patient to the hospital, and then first we have to admit the patient for the
yeah,
to the
yeah.
hospital, and
Or ඊට පස්සේ what?
uh,
Hmm.
and start on CD to resuscitation, uh, breathing, circulation,
Hmm.
and then start on the rehabilitation.
එරෙන්නේ. Mm. Nanny.
She went to change the connection and she will be back, sir. She
Shall we
got
start with someone else then? Hmm? I know. Okay. That's the cover.
only two of us were here, sir. Uh,
So what did you all go through it? Do you all
yes, I can do another question.
quickly? Hmm? Yeah.
A 6-year-old boy presents with a high-grade fever for 5 days, associated with chills and rigors. He also has a moist cough. On examination, his respiratory rate is 40 breaths per minute, and there is equal air entry. Uh, there are vesicular breath sounds bilaterally with diffuse crepitations. He had been well previously with no similar presentations in the past. Uh, what is the most likely diagnosis? Since there was a high grade fever for 5 days with chills and rigors, and
Just give me a call hospital. Hello. Sorry. Yeah. Go ahead. Hello. Hello.
Yes, sir.
Yeah. Yeah. One by one is dropping. Karandako.
Okay. A 6-year-old boy presents with a high-grade fever for 5 days, associated with chills and rigors. Uh,
Mm.
he also has a moist cough. On examination, the respiratory rate is 40, and there is equal air entry.
Right.
There were vesicular breath sounds heard bilaterally with diffuse crepitations. Uh, he,
Mm.
he had been well previously with no similar presentations in the past.
Right.
Uh, so, what is most likely diagnosis by the given scenario? The tachypneic, and there's vesicular breath sounds heard bilaterally with crepitations, and there's fever. So, I would say uh, the bronchopneumonia, uh, because
Yes.
there's no signs of any consolidation or
Yeah.
any
So they have said it is diffuse crepitations all over. You hear it. It
and
is
AI
always
also.
bronchopneumonia, but I mean, no harm saying it's a lower respiratory tract infection, most probably a bronchopneumonia.
Okay.
Right. Then,
Right, 3 investigations you would plan for this child with the expected findings. So
yeah.
I want to start with the full blood count and CRP to check the WBC levels are increased.
Yeah.
And the CRP is increased. Since there's a fever, so I want to do a blood culture and ABST to look for any pathogenic growth and the antibiotic sensitivity. To confirm the diagnosis, I would like to do a chest X-ray. Also, uh, uh,
Right.
see if there's any lobar involvement that I cannot see clinically
Mm.
for the chest X-ray. Uh,
Okay.
and like two possible organisms likely to cause this presentation: strep pneumonia and Staphylococcus aureus. Uh,
Right.
then, so the outline your plan of management for this child. Uh, since the presentation suggestive of an emergency, I will go according to the ABCD protocol to stabilize the child. Um so, in this kind of a questions, we just need to say the ABCD protocol and stabilizing
Well,
brief.
you,
So,
I mean, this child is now coming. Actually, he's not an unconscious child, no.
yeah,
So you have to actually monitor and see and supportive care you have to give mainly. So you can actually look. I mean, no harm saying that you will ensure that ABC is in one of the established ABCs prevailing here, like and basically that breathing. May airway breathing circulation is intact
intact.
and
Okay,
clinical. No harm saying that. Ensure ABC කියලා.
okay. And after that, uh, get the blood for culture and previously mentioned investigations. Then start monitoring the child with input and output, the fever chart, and then admit the child. So then start the empirical antibiotics and supportive therapy for fever, such as antibiotics, paracetamol, and uh, then
Yeah.
uh, that is the immediate management. So then,
So what outline your plan of management?
so in the
So that's basically then so you have investigations now you have done. Now you start on the monitoring. You give the antibiotics, and then you provide the nutrition to the child as
Yes.
well as hydration. Then you monitor the progress. Then, so that is the immediate management. Then you will monitor the progress and see how the child is growing with examination daily to ensure that there are no complications developed and manage. And once fever has settled after maybe 72 hours for or so of IV antibiotics, if the child is feeding okay, cough is resolving, and temperature has settled, you may discharge the child on oral antibiotics.
Okay. So the full plan I should.
Yeah, yeah. Now, in a child like this, no harm actually. You also can say that you will look in for the nutritional status, and if there are any macro micronutrient deficiencies, you will take action for that. Vaccination, whether it is complete and whether development is intact.
Okay.
Those are additional things because those are common things for all children. No, now
Yes.
in odd also you all would see. No, when a child comes, we don't just treat the temperature and send them back. We try to look into the other things also. So like that, you can bring that also here.
Okay.
Right,
Okay.
right
Uh,
then.
then list the 4 complications that can occur in the patient.
Yeah,
So in the new, since it's a list, the complications of pneumonia, such as pneumonic pleural effusion, or empyema,
uh,
lapses, and can go into septicemia
right.
and respiratory failures.
Uh, so what are the main things?
The pleural effusion,
Effusion can be there,
uh, the empyema,
right?
and lung abscess,
Empyema and lung abscess together you can put. Then
and septicemia.
mm, maybe more than that in the lung itself
Uh,
can have a pneumothorax.
yes.
Don't know, it can rupture, can a bully can rupture. Then of course, yeah. So then you can give septicemia also, right?
Uh,
Then what else? Yeah. So those are the main things. So you have to just have open mind when you are tackling these questions. And other things also you have to think of what you have been doing in the ward.
okay.
Hmm? So another question you want to do?
I got prepared for those 2 questions, sir.
Hmm? Yes. Okay. Any other question you want to do quickly? Shall we scroll through? Huh? Or not?
Yes, sir. A 11 year
Yeah.
old 11-year-old overweight girl was referred to the pediatric clinic by the medical officer of health. Her height is 154 centimeters between +1 and +2 ST. Weight is 55.5 kilogram and BMI is 23.5 between +2 to +3 ST. She attained menarche at 10.5-year-old age. Um, First question is list 5 factors uh, that you would elicit from history that is important for the management of this child. Um, in history, according to the paragraph, this child is overweight and also with a, BMI of
The
23.4.
overweight?
So
Is this child overweight?
uh,
Hmm?
+2 +3 is it's between uh, BMI is between +2 to +3 SD, sir. So
Yeah, so
it's obesity.
it's obesity. Right then.
So in history, I would like to uh, recall about the dietary habits, which probably includes the calorie intake and the consumption of fast foods and sugary drinks and other relative food habits.
So you list, no? List the 5 factors you would elicit in the history.
Okay, then it's the first one is dietary habits.
Dietary
Second
habits.
one is physical physical activity level, including screening time and
Right.
family history of any diabetes, hypertension, or obesity.
Obesity and diabetes.
Uh, then uh, s- psychological factors, including stress, bullying, or self-esteem.
Right.
History.
Then the pattern of sleep is important. Okay.
Okay, so
Because sleep itself,
and
deprivation itself leads to obesity. So physical activity, when you say physical activity, including sedentary behavior, you can try. Then sleep, then diet, then family history of any illnesses, and what else you said?
psychological factors, psychosocial factors,
Psychological factors. Yeah. Yeah. Okay. Good. Right then.
and and menstrual history because it can be PCOS or something
But
because
11-year
she's
old still,
okay.
right?
And mention 5 features in physical examination that you would look for to identify obesity related associations and complications. Uh, the first one is blood pressure for the hypertension and waist circumference for the central obesity
Yeah.
and insulin resistance factors just like acanthosis nigricans and uh, the other one is hepatomegaly, which could suggestive of fatty liver. Uh, so I thought about the factors suggestive of PCOS, such as like hirsutism or acne. Uh,
Pericamagnia, but maybe more than that, probably.
uh, mm, any
Mm,
uh,
mm.
Any syndromic features which suggestive of any syndrome, sir?
Yeah, but what sort of a child is this obesity?
Mm, Probably she has no features suggestive of any syndromes because she has attained menarche and
She has. Hmm? We have not said. I mean, okay, yeah, 10.5 years, right? But half a year, no. So it is actually, yes, it's a nutritional this thing because he's a tall, obese child. His
based.
height is above one minus, sorry, plus one SD, no.
Yeah.
So that means he's a tall obese. Tall obese is usually a nutritional obese one. Correct? So
Okay,
that,
sir.
okay, then
Um, mm, I'm not sure about that, sir. The
what?
next fifth one. Fifth one,
Fifth one? 6.3?
yeah, 6.3 is
Mocha,
the
dalaki
list
fifth one
for
ekada.
investigation.
Five
Yes,
features
sir.
and physical examination that you would look for identify obesity. Anith එක, you can look for something like intertrigo, skin rashes. There can be
Okay,
thigh rashes. There can be skin holding onto each other and getting this thing, no,
okay.
right? And yeah, that's the main thing. And then
Thank you, sir. The third one is the list for investigations you would request, giving reasons for each and the expected findings. Uh, I would start with the fasting blood sugar and for investigations. Uh, Sir, in here we have to list the four investigations. So whether we could list it in a four categories, just like related to the diabetes, related to the lipid profile.
so what are the four? No, you can. Sorry, say it again. Hello, say it again.
Yes, sir. Can you hear me?
Yeah, I can hear you. Say it again.
I want. Yeah. I want to know whether it says list four investigations. We just have to list four things and give expected findings in short form.
Yeah, yeah. Or
Okay,
investigation
sir.
types.
Then it's the first one. Okay.
Uh,
Uh, First one is fasting blood sugar and HbA1c for detect
uh,
insulin resistance or type 2 diabetes mellitus.
mm,
And the second one is lipid profiles, expecting increased triglycerides levels and decreased HDL levels. And
decrease triglyceride, decrease HDL levels. Good.
other one is liver function test,
Right.
suspecting non-alcoholic fatty liver disease with raised ALT levels.
Uh,
And third one is ultrasound abdomen for fatty liver changes.
ultrasound abdomen for fatty liver changes. Okay.
That are my four investigations.
Yeah. Okay. Then.
The fourth one is outline the management of this child. Since this is a nutritional obesity, the first the cornerstone is lifestyle modifications. Uh, we have to in outline this lifestyle modification should be family based and family-based approach with balanced diet, including reducing sugars and fats, and also the fast foods. And the meal should be regular with the controlled portion size.
Uh,
And the second one should be about physical activity. So it's should be more than
Diet is control sugar, yeah, control sugar, salt, this thing, and portion sizes should be
portions.
reduced. Variety of food should be there, right? This,
And the other one is physical activity. So based on the child physical conditions, we have to
no,
first recommend for the more than 60 minutes per day moderate physical activity.
right?
It's should be a
Coming to
stepwise approach.
adults,
It should be the stepwise approach, and also the reduced screen time. Uh, it's should be less than 2 hours per day because she's 11-year-old child. And based on the other unacceptable behaviors, just like sedentary lifestyle, we can give some behavioral support to change her day-to-day activities. And if child has any psychosocial issues with including bullying or things also. And uh, in regarding to medical management, if she has hypertension or dyslipidemia or diabetes mellitus, we have to treat the comorbidity according to the specialized advice. And later we have to arrange the follow up with regular growth monitoring. And also since it was the menarche is at 10.5 years and it's been 6 months, so we have to do a surveillance for the puberty. uh,
yeah. So it's
and
diet,
that's
physical
also
activity, sedentary behavior. You have to insist on the sleep, and then
and
you have
yeah,
to
and
see
medical
the
management
medical management of any problems,
and psychological
psychosocial
issues.
well-being, and also you have to
Well-being.
address the family issues. In the sense, you have to
Okay.
make sure that the family also fall in line with them. Yeah, they
Okay,
also
sir.
make an adjustment in the home front. You have to get a history about
Mm.
that. Now, even in the history, elicit in the history, you have to see what is the home front like. Sometimes they may be having a shop and the child may be going always there, right? Or there may be
Okay.
a relative, or there may be extended family who brings those things. They also have to be addressed. Sorry?
Okay, sir.
Right. Okay, anything else you want to discuss?
Mm,
So basically, I think, I mean, now I hope you all have a hang of that. So what you have to do is you have to think broadly, think the big picture widely. All those things you all have seen things in the board. If you just write what you have been seeing in the board itself, it's enough. What are the things we do? We will get the patient put to a bed, then make sure that the monitoring is taking place. We provide the food. Then if it is not eating, we provide fluids over either NG or oral or like that. You have to see all that. So if you take it in a broader sense, I think that would be the thing. Haridehna.
um,
So if there is anything, you all this thing gather some questions and even tell me Ruangi and I can have another day you all want.
okay, sir. We limit
Okay?
soon. Okay, sir. Thank you, sir.
හරි මොනවද තියෙනවනම් ඕන වෙලාවක even if you can I mean you all can simply jot the points
Okay,
and
sir.
come and meet me.
Okay, sir.
Right? Okay now. Right.
Okay.
Thank you. Right.
Thank you, sir.
Thank you, sir.